seem to have resolved our technical issues. Steve will be running the slides, and we're going to get into the program here and get started. If there's any issues when we get to that point, we can address it. Mary, you want to say hello to everybody, and then we'll get started?
I just want to say hello, Mary. Thank you for being here with us tonight. We appreciate your spending your evenings with us. One of the ways we fulfill our mission is through these trauma talks. Thank you for being here. I don't want to take up any more time because I'm running a little late.
Yeah, sorry, we had some technical issues. And yes, I am attached to it, so technical issues can be expected. In any event, you guys know the mission of the McSwain Trauma Education Project. The idea, Dr. McSwain's dream was to have the highest level, national level speakers and the best content possible available to providers at the local level, given that most people don't get to generally go to the conferences or might not even be able to afford some of the materials that would give them that exposure. So the McSwain Trauma Education Project does it through things like Third Thursday. We're here the third Thursday of every month. We'll talk about tonight's guest in a bit. Next month, Dr. Jeff Guy is going to be here talking about critical steps in pre-hospital burn management. We're here every month. If it's the third Thursday and it's 8 p.m. Central Time, we are here. Put it on your calendar. Make sure you can join us. Getting into tonight, let me tell you about my friend Jeff. Dr. Jeff Salomone is a native of Reno, Nevada, where he matriculated from the University of Nevada and the University of Nevada School of Medicine. He relocated to New Orleans, where he completed his surgery residency in surgical critical care, working with Norman McSwain, who has started this as father of our project, basically. He was a residency director there. Then he joined the faculty at Emory University, where he began his career as trauma and critical care surgeon based at Emory. During his 16-year tenure at Emory, he rose to the level of associate professor and served as assistant director of Grady EMS, director of trauma sustainment program for the U.S. Army Special Operations Combat Medics, and the interim trauma medical director for Grady. For 15 years, he was the Atlanta police surgeon, another example of him following in Dr. McSwain's footsteps, and took care of officers injured in the line of duty. In 2013, he became the division chief of trauma and surgical critical care and trauma medical director for the Maricopa Integrated Health System, previously the Maricopa Medical Center in Phoenix, Arizona. In 2016, he joined a private surgery practice in Mesa, Arizona, where he's named director of trauma and surgical critical care and the trauma medical director for the Banner Desert Medical Center, BDMC. Over the next 6 years, he led BDMC to organize and open both adult level 2 and pediatric level 2 trauma programs and achieve successful verification through the American College of Surgeons. Having become nationally certified as paramedic during medical school, which again makes him a great addition to our speaker team, as again, he began in pre-hospital care and got to the point where he is following his pre-hospital experience. He's been a central theme throughout his career of pre-hospital medicine. And for more than a decade, he was an associate medical director for PHTLS at National Association of EMTs. He also served 2 terms on the National Committee on Trauma at the American College of Surgeons, including 4 years as chairman of the EMS committee. Dr. Salomone was honored with being named to the inaugural National EMS Advisory Council at NEMSAC of the U.S. Department of Transportation, and also served as second term on NEMSAC. Jeff was president of the Eastern Association for the Surgery Trauma, commonly referred to as EAST, serving from 2012 to 2013, and he currently resides in Tempe, Arizona. So without further ado, I'd like to introduce my friend, Dr. Jeff Salomone. We were talking about it earlier about who's going to do this introduction. He just said, well, you've known me the longest. And we're still friends, so that's a good indication. Yep. So, yep. Dr. Salomone.
Thank you, Will. Thank you, Mary. And thank all of those of the McSwain Trauma Education Program. So if you can hear me, we can get into the slides. Thank you to all who are attending, taking time out of their evening to spend a few minutes talking about pre-hospital blood transfusion. All right, Steve. Next slide, please. So what I'm going to do, the focus of this is on the blood, which is the second half of this, but I'm going to talk a little bit about how we got to that point, how we got to where we are with modern resuscitation. So we're going to look at what has been the traditional approach to managing hemorrhagic shock, transition to what we now call damage control resuscitation, and then look at the studies behind transfusion of plasma, packed cells, and and the newest information is low titer Group O whole blood. So next, Steve. Just as a little background refresher, the components of a sample of blood is that it contains three things primarily. Plasma, which is the liquid part of the blood containing the blood clotting factors and electrolytes, also immune proteins. The platelets and white blood cells are the next layer. They account for only about 1% of the blood volume. Platelets, of course, are crucial for blood clotting. And then about 45% of the typical sample of blood are red blood cells. So this is a sample of blood spun down, the plasma's on top, red cells on the bottom, white cells and platelets in the middle. And of course, the red cells carry oxygen, and the percentage of red cells we commonly call the hematocrit. So you may hear that or see that on a complete blood count. Next, please. So in terms of perspective of this, it's interesting that we're kind of coming full circle, because during World War II, there was blood plasma transfused to individuals in the battlefield, and then whole blood was available in hospitals. Blood transfusions were fraught with many problems up until the early 1900s, and that's because people didn't understand blood types, and attempts at transfusing blood. You know, everybody's blood looks the same, so you give it from one person to another. It would sometimes result in death in a hemolytic blood transfusion reaction. By the time we got into the Korea and Vietnam conflicts, balanced salt solutions, what we now call crystalloids, lactated ringers, normal saline, were very, very common. And in fact, this was used a large amount for resuscitation, especially in the pre-hospital setting. And this led to the creation of a problem called Da Nang lung in the Vietnam conflict was described, which we now call adult respiratory distress syndrome. And in large part, the crystalloids may have contributed significantly to that. Advanced trauma life support, program from the American College of Surgeons that we've all, or that we follow, and the pre-hospital trauma programs are based on. The traditional approach that they always used was for an adult, a bolus of 1 to 2 liters of crystalloid, ideally warmed, or about 30 milliliters per kilo for an adult, 20 mils per kilo for a child. And once that bolus is given, if the patient is still in shock, you think about blood components. And we'll come back in a couple minutes and talk about how ATLS has advanced since this approach. Next, Steve. So blood banking began a component. As I mentioned, plasma was given in the field in World War II, whole blood in hospitals. But it was in the 1960s, and it's not really clear to me what the motivation was for this, whether it was we could help more people by taking a unit of blood and separating it out to different components, or whether we could make more money taking a unit of blood, separating it out into different components. But a unit of blood began being broken down into what they called packed red blood cells. So instead of a hematocrit of about 45, it's now hematocrit of about 70, 75. Mostly cells, that's why they're packed, and very little fluid in that. And they would be banked, and they last 6 to 7 weeks in a blood bank, refrigerated. The liquid part, plasma, is typically frozen, and you can see why here, and that's because when you freeze plasma, it can last up to a year as opposed to just a couple days when it's fresh plasma or thawed plasma. So thawed plasma refers to taking a unit of fresh frozen plasma and then thawing it out. And that's done in many trauma centers that they have plasma available because you don't want to wait the 20 to 40 minutes it takes to thaw out a unit of frozen plasma to have plasma immediately available to transfuse. So once it's thawed out, it's good for up to about 5 days. And then platelets are, the interesting thing about platelets is they are not refrigerated. They will clump together if they are not continuously agitated. So platelet packs in a blood bank are usually sitting on a device that just rotates back and forth. It keeps these platelets moving around. And then in addition to packed red blood cells, plasma, and platelets, all separate components you would order from the blood bank, there are also other factors, like factor VIII is the one that's typically deficient in the most common form of hematophilia and or hemophilia. And so for a patient with hemophilia, you'd order factor VIII transfusions, be able to get that, not have to give all the other components. Next slide. So in terms of the coagulopathy of trauma, for many, many years, and back in the days where many of us first got into trauma care, there's something that was referred to as DIC, disseminated intravascular coagulation. And true DIC very rarely occurs. What we were calling DIC was really a consumptive coagulopathy. You know, the patient's blood clotting factors were in the suction canister or on the floor or on the gurney. You replace them with IV fluid and further diluted out the remaining clotting factors. So the more accurate term for this is consumptive coagulopathy, where you use up your blood clotting factors or they have left the body through exsanguination. The other thing to mention here, and that consumptive coagulopathy, many of you have seen the triangle of death, the hypothermia, acidosis, coagulopathy. More recently, they've added a fourth line into this. So it's now more of a diamond, and that's hypocalcemia. And that's because calcium plays an important role in blood clotting. There's a problem that was identified in the 1990s called early trauma-induced coagulopathy, or ETIC, sometimes just called TIC, trauma-induced coagulopathy. And there are some trauma patients, even though they've not gotten cold, not gotten IV fluid, that just arrive at the trauma center with an elevated INR, a clotting test that shows their blood is thin. And this is somehow related to genetics that we don't yet understand. So some patients, just from being injured, develop a coagulopathy. Next. So many of you who've been through nursing school or medical school, I don't think most paramedic programs spend too much time making people memorize the clotting cascade, but it's a bane of many of us who've done more advanced training. All these different clotting factors, they're broken together into an intrinsic pathway and an extrinsic pathway. They come together and then form what's called the common pathway. And you'll see places in here where there are calcium ions that are required in order to, these are all enzymes that catalyze the next step. And the enzyme works best when calcium is present. So if you've lost a lot of blood and you're hypocalcemic, giving calcium can play a major role in improving your blood clotting. Next. So on the right side, I just threw in here the vitamin K dependent factors, factor 2, 5, 7, and 10. And that's because these are the factors that warfarin or Coumadin affects. So when you take care of patients who are on warfarin or Coumadin, they have problems with these factors 2, 5, 7, and 10 working. The more novel anticoagulants that are on the market, Xarelto and Eliquis, are direct thrombin inhibitors. So down where you see thrombin, that is where they act, not through the vitamin K dependent factors. Next. So getting into the more recent era, in the 2000s and more recently, things that were learned in the Afghanistan and Iraq conflicts. And again, trauma care always makes large leaps during military conflicts because there are lots of injured people and lots of money spent on saving soldiers. And so, and learning, doing research, understanding how to do things better. So one of the first things that came out of the Afghanistan-Iraq conflict was something called damage control resuscitation. And then component transfusion, as opposed to when I was in training, we gave a lot of red cells. And then if you checked PT, PTT and they were, the numbers were elevated, you would give FFP. And if the platelets were low, you'd give platelets. But now there's an approach to try and balance 1 unit of packed cells to 1 unit of plasma to 1 unit of platelets. And then as people began to do that, they realized, well, maybe we should just go back to whole blood where everything's in one package and use that for blood transfusion. Next. So damage control resuscitation consists of 4 different components. One is hemorrhage control. So pressure dressings or tourniquets, things, wound packing, hemostatic agents, anything that can control the external hemorrhage as much as possible. The next component is what we call balanced resuscitation, and that's limiting your crystalloid to prevent that dilutional coagulopathy and accepting a lower blood pressure or mean arterial pressure before hemorrhage is controlled. And so we may tolerate a blood pressure of 80 to 90 systolic in a gunshot wound to the abdomen while we're rushing the patient to the operating room, because we don't want to restore that blood pressure back to normal because bleeding may worsen internally. The next is a hemostatic resuscitation, which is this 1-to-1-to-1 approach that when you resuscitate patients with blood, you give plasma and platelets in addition to packed red blood cells. And then continued focus on acidosis, hypothermia, and hypocalcemia, keeping your patients warm, aggressively resuscitating them to reduce acidosis, and administering calcium. Next. So the most recent version of ATLS, which came out about 3 years ago, 3 to 4 years ago, next version I believe is due out next year. Gesundheit. The next edition, or the current edition, 10th edition, has gone from that 1 to 2 liter bolus in adults to just 1 liter or 20 milliliters per kilo of crystalloid solution. And if the patient's still in shock after getting a liter, or a kid 20 per kilo of crystalloid, you move to blood. And it's so focus on earlier blood products, especially in what we call the transient responders and the non-responders. And if possible, that 1-to-1-to-1 transfusion. And this version of ATLS, as well as the last, continue to support the idea of balanced resuscitation, sometimes called permissive hypotension, especially for penetrating trauma, until you're able to control bleeding, and then you can restore their blood pressure to normal. The next edition of ATLS will probably focus more on whole blood, because whole blood was relatively new when this 10th edition was being written. Next. So with that as a background, now we're going to start focusing on what the topic is tonight, and that's giving blood in the pre-hospital setting. And there are a number of challenges about blood transfusion. Blood is a limited resource. You know, a couple times a year, or maybe more than a couple times a year, you'll hear on the radio or television stations that the Red Cross or your local blood bank is short of blood and asking people to go donate. Blood transfusions or blood donation went down markedly during the pandemic, during COVID, and has never returned back to pre-pandemic levels. And so it's an even more limited resource. So there's tremendous amount of research ongoing of how we use blood most wisely. And then there's the issue of incompatibility and typing. And I've got a slide coming up that describes the different blood types. But universal donor products, you've probably heard of a universal donor. And for red cells, that's O negative. And for plasma, it's AB plasma. So if you've got a patient, regardless of their blood type, you can give O negative red cells. And regardless of their blood type, you can give AB plasma. Blood is expensive. A typical unit of red cells would cost the hospital somewhere around $350 to $500. There's an issue of wastage of blood. If red cells sit out at room temperature for more than 30 minutes without transfusing, they need to be discarded. You can't put them back in the refrigerator. And that's because of the risk of bacteria growing in it and then transfusing that. And so we want to minimize wastage as much as possible, considering it's a limited resource. And then there's been an issue around the country as we've looked at pre-hospital blood transfusion about training and scope of practice. And if you're in a hospital or a hospital setting and a patient is getting transfused a unit of blood, there are two nurses that have to check the patient and check the blood as the blood is being administered. And that's because this is cross-matched blood. You want to make sure that it's compatible with the patient's blood type, and the donor unit you're going to transfuse is of the identical type. And in an EMS setting where you've got one paramedic, usually it requires two licensed personnel in the hospital, two RNs, an RN and a physician, to sign off on each unit of blood that's being transfused. Pre-hospital setting, you've got just a paramedic is potentially licensed person, and so they don't have that ability, but we're really only giving one type of blood in the pre-hospital setting. And I'll explain that a little bit better. But many, while nurses have blood transfusion in their scope of practice, most states have not allowed paramedics to initiate blood transfusion. They've been allowed to continue a unit of blood that was started in a hospital during transport. And so there's a scope of practice issue that had to be addressed here in many places in the country. Next. So plasma, I'm going to talk about these components a little bit more in detail. Plasma can come in three different types. Fresh frozen plasma, as I mentioned, has a 1-year shelf life, and it's stored at -18 centigrade or about 0 degrees Fahrenheit. The thawed plasma has a shelf life of 1 to 5 days. It's kept refrigerated 2 to 6 degrees Celsius, so about 36 to 42 degrees, and it'll last for up to about 5 days. Liquid plasma, this would be plasma that's taken from a unit of blood but never frozen, has a shelf life of 26 days. So the shelf life is much shorter when you thaw a unit of frozen plasma. But liquid plasma is stored at 2 to 6 degrees Celsius for 26 days. And then something that's been looked at a lot, military has looked at this. There are other companies looking at this, is freeze-dried or lyophilized plasma. You freeze-dry the plasma just the way you freeze-dry coffee. And then it could be reconstituted at bedside when a patient needs plasma. The great thing about this is that most ambulances don't carry refrigerators that are going to go down to 36 to 42 degrees, whereas you could store this lyophilized plasma on an ambulance. And when you get a trauma patient, you could just add the liquid to it, restore it to a unit of plasma, and transfuse that as you go to the hospital. So there's been a lot of focus on freeze-dried plasma. There's nothing yet FDA approved in this country. Next slide. So I'm going to look at first a couple papers that looked at pre-hospital administration of plasma. And this first is one of the earlier studies that was done. It's from the New England Journal of Medicine, called the PAMPER trial, and it's pre-hospital plasma during air medical transport in patients at risk for hemorrhagic shock. So this was designed as a prospective randomized cluster randomized trial. And their goal was to have 501 trauma patients who were in shock. It was centered around the University of Pittsburgh and some other trauma centers in the Metro Pittsburgh area, and involved 27 air medical bases flying patients to these 9 trauma centers. So they would carry 2 units of thawed plasma, either AB or type A plasma that's very low B titer. And I'll explain that a little bit more in a second. And they compared that versus standard resuscitation crystalloid. So 1 to 2 units of thawed plasma versus crystalloid. And was randomized. 230 patients got plasma, 271 received standard care. The PT prothrombin test, or INR, on arrival, the hospital was lower in the plasma group, so the plasma did seem to improve clotting function. Now, if you look at these numbers, 1.2 versus 1.3, you'd think that couldn't be statistically significant, but it was with this sample size. The most important thing is the patients who received plasma had a lower 30-day mortality than the patients who got crystalloid. So their mortality was almost cut in half, so or cut by a third. So the mortality was 33% in those who got crystalloid and only 23% in those who got plasma. So that data supported pre-hospital administration of plasma. In terms of complications, there was nothing different. Next slide. The next 2 slides have information from what are called secondary analysis of the PAMPER trial. So when PAMPER was being conducted, there was information that was collected and put in a database. And when you create a study like this, you have endpoints in mind. Clearly, mortality is one of them. These secondary analyses are now going back to the data that was collected to ask other questions that weren't really thought about when the initial PAMPER trial was done. So there are 4 more studies off the PAMPER database. These aren't as good as if the studies were designed for this, but it still can give you some information. This ATOM study looked at, they had over 5,000 plasma units that were deployed over the 42 months of the PAMPER trial. Of those 5,000 units, 5,100 units, only 7.2 were transfused and 72.8 were returned to the blood bank. So there's a constant rotation of this blood. But of significance is that 20%, almost over 1,100 units were wasted in this. And that's a huge number. You know, we freak out in a trauma program where we waste 1 to 3 units of blood a month. But having 20% of the blood that's issued wasted is pretty expensive. And then the annual cost per base was between about $25,000 and $30,000 for a blood program. And so if your program has 10 helicopter bases, you're talking about a cost of over $300,000, $250,000 in order to provide blood in the pre-hospital setting. So it is expensive. The next study looked at just the patients enrolled in Pamper who required a massive transfusion, the MTP initiation, the massive transfusion protocol. And in those patients who required massive transfusion, they saw no survival benefit to 2 units of plasma in the pre-hospital setting. However, the survival benefit was most robust in the patients who only needed 4 to 7 units. So I think one way to think about this is patients who were bleeding profusely, 2 units was a drop in the bucket and didn't matter much. But patients who may have had a crack in their liver or spleen or fractures that were third spacing blood, you give a couple units of plasma, and it helps slow down the bleeding. And these patients just require a couple more units of blood and not a whole blood massive transfusion protocol. Next slide. This next study looked at what they considered to be unexpected survivors. So we have the way of looking at a patient's injuries and predicting whether or not we think the patient should have survived or should have died. And so an unexpected survivor would be an injured patient who is thought to be severely injured to the point where they really shouldn't have survived, but they did. So they looked at the subgroup of unexpected survivors, and they tended to be younger, more severely injured, had worse organ dysfunction, but administration of pre-hospital plasma was associated with an increased number of unexpected survivors. So you took patients who probably wouldn't have survived and gave them plasma, and they survived. This last study from Pamper looked at some air medical programs that also carried packed red blood cells. So some of these air medical programs carried both plasma and packed cells. Some carried only packed cells, some carried only plasma. And then some patients got crystalloid alone. That was the control group in the original Pamper study. So what it showed was that mortality was significantly lower in the patients who got plasma than in the crystalloid only. And if they got both packed cells and plasma, their survival was better than if they just got plasma. But if they just got plasma, their survival was better than if they just got packed cells. And then the patients who got only crystalloid had the worst survival. So that's the Pamper analysis, and then 4 other trials that were based on the patients enrolled in Pamper. It's a lot of data from 500 patients. Next slide. So this next study, even though it's published in a British journal, Lancet, was conducted in Denver, Colorado. So a single ground EMS system. It was prospective, randomized, called the Control of Major Bleeding After Trauma, or the COMBAT trial. And here patients were randomized into either 2 units of thawed AB plasma, followed by standard care crystalloid if they were still hypotensive, or just standard care as the alternative, the control group. And there were 125 eligible patients, and you see 65 received plasma, 60 got saline, and groups had similar demographics, but the mortality group in the mortality rate in the plasma group was actually higher than the mortality in the saline group. So about 50% higher, but the numbers are pretty small, and it was not statistically significant. However, this study was discontinued early because the interim analysis showed lack of efficacy. So they didn't continue the study because the mortality rate was not statistically different between these two groups. So whereas Pamper showed a significant mortality advantage, a decrease in mortality, the combat trial did not. Next. So now there are a couple studies we'll talk about where some authors took the data from both the Pamper and the combat trials and combined them to take a look at things. Dr. Pusateri is a military researcher. He's done a lot of work on topical hemostatic agents, tourniquets, and resuscitation during the early 2000s and into the 2020. And what he found was that when you controlled or adjusted the data for injury severity and age, there was a significant survival benefit associated with plasma. And that this mortality, or that there is an increased mortality rate when in the standard group, the crystalloid group, when the pre-hospital time was greater than 20 minutes. You did not see this increased mortality in the plasma group. So again, this thought that the quicker you get patients to care, or the quicker you initiate care, that is, give plasma in the field, that mortality, increased mortality disappeared. This last study looked at, again, combination of Pamper and combat databases, and they focused on blunt trauma patients, and they had higher injury severity, age, and lower GCS scores, so seemed to be more severely injured. And what they found is blunt trauma patients who received plasma had a 32% lower hazard for 28-day mortality. So the hazard ratio was lower for these patients. And so plasma affected blunt trauma, but they saw no survival benefit in penetrating trauma patients. Maybe again, that's because they fell into that group that needed massive transfusion and were bleeding too much for 2 units of plasma to make a difference. Next. So this next study is from the United Kingdom, published in Lancet Hematology, and it was a randomized multi-center trial of 4 civilian pre-hospital services in the United Kingdom, and they were adult patients age 16 or older with hemorrhagic shock, and the patients would get either up to 2 units of packed cells and lyophilized plasma. Again, this is freeze-dried plasma that's reconstituted at the scene, as opposed to liquid plasma or thawed plasma that was being used in the United States. So this lyophilized plasma was approved at least for study in the United Kingdom. And they looked at 432 patients. About half got the red cells versus plasma and half got crystalloid. And their goal was really to enroll 490 patients, but they had to stop at 432 because of the pandemic. But when they analyzed these databases, the outcomes were not statistically different. So the combo of red cells and lyophilized plasma versus crystalloid, there seemed to be no survival advantage in this British study. Next. All right, so here's the big one, the newest one, the hot thing in the hot take is whole blood. And we call it low titer O positive whole blood. And what the low titer means is that O blood has no antigens on the blood cells, but has antibodies in the liquid part of the blood. And so the O positive has very low titer, means very low anti-A and anti-B antibodies. And so one of the questions is can you give this to any blood type? And so people were concerned about giving O blood to women of childbearing years for fear they developed a risk of having blue babies or Rh incompatibility. And then for very young patients, there was concern about giving type O blood that they then develop antibodies against these antigens that are present. Next slide. So this just reviews blood types with you. Group A has the A antigen, which is shown here as the red dots on the cell. Group B has the group B antigens on the red cell. Group AB has both, and group O has neither. And then in the plasma, the group A has anti-B, and group.
Oh no, you were up there with them, so you will help them.
Yeah.
Okay, let's go.
Can somebody mute their phone, please?
Yeah, please, everybody, make sure you're muted. We're hearing some collateral noises.
So group B has the anti-A antibodies, and AB has no antibodies. That's why it's the universal donor plasma. And then group O is the universal donor red cell because it doesn't have any of the antibodies on it. And then people with Rh positive blood have another antibody on their cell, and Rh negative don't have that antibody. Next. So this is an in-hospital study, one of the earliest published, looking at the safety and impact of low titer group O whole blood for emergency use in trauma. So this was in-hospital patients receiving whole blood. And again, while this became the standard in the military, because they have a walking blood bank, they can just draw blood from their military personnel, whole blood, and administer it to those who need it. And low titer whole blood to those patients who, versus those patients who received only red cells plasma or red cells and plasma. So 198 in the low titer O whole blood and 152 in the other group. The group that received the whole blood had more severe chest injuries. That's what the higher chest AIS score means, and worse arrival-based deficit, meaning they had more physiologic derangement, were in more severe shock. And what this study showed was there's a 53% reduction in post-ED blood transfusion. So that means after the patients left the ED, either in the operating room or during the ICU or floor stays, they received less blood products than those who received component therapy. And they they had a survival that was twice as high. So this really supported the use of whole blood rather than component therapy. Next. So this is really getting to the meat of the pre-hospital whole blood transfusion. This is study published only in 2022, so not that long ago. They were primarily looking at feasibility, whether it's feasible and safe of giving group O whole blood. Air medical bases randomized to either give low titer whole blood or standard care, packed red blood cells. And then hypotensive trauma patients would receive up to 2 units of O whole blood or up to 2 units of packed red blood cells. So there's no plasma being given to the control group there. So the goal was 112 patients, 56 in each arm. They only got as far as 86 patients enrolled, so only about 70 to 75% of what they were looking for. Part of it was stopped because of the pandemic and low accrual of patients. And then there were also some financial concerns. But of these, they had 40 who got whole blood and 46 who got standard care. And most importantly, they showed that transfusion of low titer whole blood seemed both feasible and safe. And when they looked at the mortality, there was really no difference between the two groups. But again, the study wasn't designed to look at mortality. It was designed to look at feasibility and safety. So you need more patients to look at mortality impact. Next. So most of the data in this country about pre-hospital whole blood has come from Texas and this regional whole blood program that's focused in San Antonio, Texas. And this paper was published at the end of 2022. It's a 3-year update on pre-hospital and in-hospital transfusion practices. And there's something called the San Antonio Whole Blood Collaborative that was formed in 2018. And this involves the South Texas Blood and Tissue Center, which is the blood bank for this region, the Southwest Texas Regional Advisory Council, which is the EMS oversight body for this part of Texas, and then the 2 level 1 trauma centers in the region, Brooke Army Medical Center, they do take civilian trauma, and then the University Hospital at UT San Antonio. So this area covers 22 counties and 26,000 square miles. Huge area. It's covered by 13 helicopter EMS systems, 25 ground platforms. And in San Antonio, there are 49 units of blood deployed throughout these 22 counties at any time. Next slide. So if you look at the bottom right of this diagram, the map of Texas, the blue area shows the 22 county region. Then you go up to the upper middle, and this is a blown up area of the 22 counties. You see most of the pins, green pins are level 4 trauma centers. The yellow pins are level 3 trauma centers, and there aren't many of those, just 3 of them in the region. And then 2 level 1 trauma centers, Brooke Army and UT San Antonio. And they're most focused in the one county. And so then the bottom left shows the location of the hospitals within that central county, which has the 2 trauma centers. This is the area that contains the city of San Antonio. Next. So this pre-hospital low titer whole blood program was initiated for trauma patients. And so it was initially started for shock due to hemorrhage. The program was expanded to include pediatric trauma resuscitation, and then females of childbearing potential, usually obstetrical hemorrhage, and then non-traumatic hemorrhage, massive gastrointestinal hemorrhage, or suspected aortic aneurysms. Next slide. So this most recent study is a review of the San Antonio data, and it's looking at low titer whole blood versus no pre-hospital transfusion, so crystalloid therapy. And all they could see from this low titer whole blood was that it had a lower trauma bay mortality, which means that the fewer people died in the trauma bay. So clearly you have to survive the trauma bay to survive your hospital stay. But what that would mean is that while it was lower in the trauma bay, those patients went on to die sometime during their hospital stay. So this was not statistically significant. And in patients who were in cardiopulmonary arrest, they had no benefit from getting whole blood. So you shouldn't waste whole blood on patients in traumatic cardiac arrest unless you get a perfusing rhythm. Next. So this study was just published last year. He published almost a year ago, April of 23. This includes both trauma centers in San Antonio. Again, comparing low titer whole blood versus pre-hospital non-whole blood, so packed cells or plasma. You see that they've historically had blood pre-hospital for a long time. So 1,300, almost 1,400 patients in that group, and 171 in the low titer whole blood group. And here, the patients who received whole blood had a lower mean ISS score, injury severity score, meaning they were less severely injured than those who got packed red blood cells. But they had a higher shock index, indicating worse physiologic derangement. And the next slide shows the outcome. So the giving low titer whole blood was associated with improvement in the shock index. So they had less shock when you gave them pre-hospital blood. The patients who got low titer whole blood required fewer massive transfusion protocols. So about 50% less, 32% versus 22%. And that was statistically significant. So one of the thoughts about whole blood is if you give whole blood up front, that has both platelets and plasma in it, red cells are transporting oxygen, but you give the plasma and the platelets, they may have some hemostatic effect and stop bleeding inside the body so that they don't require massive transfusions later on down the road. And then the mortality and length of stay were similar across both groups. So even though they got less MTPs, whether they got low titer whole blood or packed cells, their mortality and length of stay were not statistically different. So that's kind of disappointing because there's a lot of hope placed in the whole blood. All right, on to the next. So in summary, pre-hospital transfusion of plasma, RBCs, and low titer whole blood appear to be both feasible and safe. So paramedics can administer this and patients tolerate it very well. Clearly, pre-hospital transfusion is costly and labor intensive because you're having to keep these products cold. You have to rotate them so they don't expire on the EMS units. As we mentioned from the PAMPER trial, pre-hospital transfusion of thawed plasma appears to have a survival benefit primarily in blunt trauma, and that transfusion of packed cells and plasma has shown mixed results. Some better, some worse. And then while low titer whole blood is associated with improvements in vital signs, trauma bay mortality, the long-term survival benefit really hasn't been seen. So the last two slides here are kind of summarizing the pros. The pros of pre-hospital transfusion is we know from many, many studies that the time to initiation of transfusion is the most important factor with improved survival from hemorrhagic shock. And so the quicker you can give the product, you'd hope that would improve patients. And then transfusions not associated with any decreased patient safety. There's no data showing that pre-hospital transfusion has hemolytic transfusion reactions or the patients have complications from pre-hospital transfusion. And there's at least one study that shows very low wastage, but I showed the PAMPER trial that had huge percentage of wastage of plasma. And then lastly, the cons would be that available studies don't show any improved survival or secondary outcomes. And then the studies are confounded by unanticipated control group characteristics. This is an interesting analysis that the 30-day mortality was 3 times higher in the PAMPER group than combat. So you have a trial being done in Pittsburgh and a trial being done in Denver, and their mortality rates are markedly different. And in fact, if you look at the combat group, which had an injury severity of 27, more severely injured, who got saline only, they did better. They did better than patients who got the intervention, that is the red cells and plasma, in the pamper group. So it's hard to tell when you start comparing study to study. And then lastly, some people have thought that the benefit of plasma may not be the replenishment of coagulation factors. Our simple thinking is that if you give plasma, it's replacing clotting factors that have been lost. But there are those who think it's more related to plasma's effect on vascular permeability and initiating inflammation, that giving plasma controls these things. So with that, I think there is, I liken this to pre-hospital intubation. It sure seems to be a good idea, but finding data to support its use is a bit of a struggle. And so let's go on to the next slide. I'll thank you all. And then Steve, the last slide is about one more. Yes, the Pre-Hospital Blood Transfusion Initiative Coalition. And John Kramer, who is the former director of the Office of EMS at the National Highway Traffic Safety Administration, is on the call. And he's involved intimately with this Pre-Hospital Blood Transfusion Coalition. So I thought it would be worthwhile to have him say a few words at the end of this presentation.
Thank you, Jeff, and phenomenal presentation on both the background of blood therapy and its application in the field. As you alluded to, it has been picking up in the pre-hospital setting, starting in the mid-2010s, 2015, 2016. Folks started to do it. The Pre-Hospital Blood Transfusion Initiative Coalition is a collaborative that started last summer, really to bring folks who are either doing or thinking about doing pre-hospital blood programs together, just to help facilitate information collection, coordination, sharing, and things like that. A multidisciplinary collaborative with folks from the EMS community, the blood community, trauma, emergency medicine, really trying to focus on a couple of things. I'll refer you all to the website. It's simply prehospitaltransfusion.org. We have 5 areas of focus, but the 2 most important you have already alluded to. One is scope of practice. As best we can determine, about 20 states currently allow EMS clinicians to initiate blood transfusions in the field. 40 plus of them allow maintenance of transfusions if they've already been started someplace else. We're currently doing a study in conjunction with the National Association of State EMS officials to get a better handle on the specific scope of practice issues that states are being faced with. The other big issue, and you made reference to this, has to do with the cost of these programs, because currently there is no reimbursement available by third-party payers for either ground or ambulance programs initiating transfusion in the field, with the exception of hospital-based programs, and then they're sort of playing with the payment mechanisms. So we're doing a lot of work right now on both scope of practice and reimbursement issues. One of the other things that we're doing is working on developing a database of all ground and air programs that are currently conducting transfusion programs. Dr. Randy Schaefer, who is a retired military trauma nurse, is on the call, and she is coordinating that activity for the coalition. Randy, if you don't mind, if you're still on, please put your email address in the chat. If any of you have programs and have not already communicated with Dr. Schaefer, please do so that we can make sure that we are aware and have information about your program. As best we can determine right now, there are about 135, maybe somewhere around in there, ground programs in the United States that are conducting that. The coalition is agnostic to the type of blood component, whether the program has whole blood, packed cells, plasma. It's agnostic to the type of hemorrhagic shock. Folks typically talk about hemorrhagic shock as a result of traumatic injuries. Some of the programs, quite honestly, are finding that they're transfusing blood in medical patients more frequently than they are in trauma patients. So it is agnostic to the cause of hemorrhagic shock. It's agnostic to the EMS delivery model. We are extremely interested in anybody and everybody who is potentially interested and would like to help with some of these activities. I will put both the website address and my email address in the chat. If folks have further questions, please refer to the website. Send me an email. We're happy to engage with anybody. In view of the time, if there are any particular questions or anything else that you are looking for, Jeff, please let me know.
No, John, that's just perfect. A great overview of that resource that people have.
Well,
Dr.
thanks.
Salomone, Dr. Salomone, we do have one question and this is from Dr. Pons. His question is, should all trauma patients in hemorrhagic shock receive pre-hospital calcium, even if blood is not available?
Wow, that's a great question. I've never thought of it.
Of course, it's Dr. Pons.
Well,
I know.
Jeff, if you don't mind, because we have been talking about that as we're looking about the protocols, it has to do with not only the blood products, but things associated with it. There are a number of folks that are suggesting that, yes, if they are in hemorrhagic shock, one may want to consider administering IV calcium. That has not been well studied, so we don't know the answer to that. But great question, Peter.
Yeah, I wouldn't have a problem with it. The downside of giving it to somebody in profound shock is minimal, and those who've taken care of critically ill patients in severe shock, it's amazing watching a blood pressure go up when you just give an amp or two of calcium to these patients in the operating room.
Thanks, Dr. Salomone and my buddy Jeff. That was a great presentation, and it was enjoyed by many. Early on in your presentation, I chose not to interrupt you. Some folks were asking about what type of fluid warmers people are using, and there was a little bit of a sideline conversation going on where folks said they're using Thermal Angel, other folks said they're using QuinFlow, and they also started to talk about, okay, so you've got it, how do you secure it to the vehicle? And I guess I would open this up certainly to you and Dr. Kramer, but also to Randy and any of the rest of the folks that have been working with blood programs.
I do not have any experience with pre-hospital fluid warmers. We, of course, use fluid warmers in the trauma bay in the operating room when we're caring for trauma patients in hemorrhagic shock. But I cannot speak to any experience with that, personal experience.
Randy, what's your experience working very closely with many of the agencies?
Yeah, I would say there's a lot of folks out there using the QuinFlow. I think Quantum also has one. The great part about it is the technology has improved a lot, especially from when I was, back in the old days in the war. From the technologies that we have, they really are developed for the pre-hospital setting, where they're compact, the battery are smaller. lots of options out there. So, you know, 3 principles of blood, Prehospital blood program, keep the blood cold until you need to warm it up and infuse it fast.
Thanks a lot, Randy. There's another question or a comment about including TXA, and I know, Jeff, you mentioned that even with blood, the data sometimes doesn't support what seems to be a good idea. TXA has been on both sides of this too, and I know Dr. Lance Stuckey's on the call tonight too, along with several others. What's your thoughts and Dr. Kramer's thoughts on TXA, and maybe something from Lance too while you're here too? I mean, Allison is here too with us, I think, from.
I missed Lance's presentation when he did it on a Thursday night trauma talk. So I don't know what he's going to say, but I'm not convinced that TXA really makes a difference. It used to be a moderately complicated administration approach of a gram over 20 minutes, followed by another gram over 8 hours. I think the military has done a lot of work looking at giving a gram or 2 IV push and seeing similar results. But when you're in the middle of a massive transfusion or giving whole blood, I'm not sure that it really makes a whole lot of difference. We often forgot it, but I'll stop there and let Lance or somebody else share their opinion on it.
I mean, I can chime in, Jeff. I agree with you. So I could defer to Peter Pons because he can give my answer for me. I think we're on the same page on this, but I think there's very little data to support its use. I think it's a drug in search of an indication, especially in the pre-hospital setting. We routinely forget it at our trauma center because I think most of us don't think it actually makes a difference, especially without good TEG data to show that there is true hyperfibrinolysis going on. So, you know, there is some data that might be beneficial in head injury, especially a single 2 or 3 gram dose instead of the traditional 1 gram followed by the 8-hour infusion. But I'm not sure that, you know, it really does make a real difference. It's inexpensive, it's safe, so those are the upsides to it. Probably not a lot of harm to giving it, but I don't think it's as good as the data out there tries to make it out to be.
Thanks, Lance. Dr. Pons, Lance didn't throw you in front of the bus, but he certainly put you on the bus. Did you have any did you have any comments you wanted to make in that regard? Maybe we lost Dr. Pons. He might be gone. Allison?
Yeah, I agree with everything Dr. Stuckey said. I think, you know, here we have the acute resuscitation care bundle that New Orleans EMS started doing about a year ago, which includes the 2 units of packed red blood cells, 2 grams of TXA, 2 grams of calcium. And we did see a mortality benefit. Those are really small sample size, and there were definitely some confounders. I agree that I don't think it hurts. I typically will just give 2 grams at once. I usually don't do 1 gram and then wait and give the other. But we're still trying to tease out, you know, what really is making the difference. Is it the blood? Is it the calcium? Is it the TXA? Or is it all of those things together? So I think there's still more to come in that arena.
Thanks, Dr. Smith. Dr. Kramer, has this collided with some of your efforts on the commission?
I'm sorry, Will, I'm not sure I understood the question.
Has TXA factored into what you guys have been looking at as far as using blood for resuscitation? Has that worked into any of the protocols you guys have been looking at?
We're actually in the process right now of collecting a lot of the protocols. There are some that have included it, others that haven't. I think the general sense among the discussions and the collaborative it's probably, if it's given as a single 2 gram dose, it's probably worth considering. The splitting it up 1 and 1 doesn't make a whole lot of pre-hospital sense.
Thank you. The questions on warmers, if you look in the comments section, folks are talking about manufacturers providing warming cabinets and some other things that may or may not be there for you, but there's some comments there for you.
Will, I saw in the comments from, I think this is the Dr. Marvin Wayne.
Yep.
Talking about giving 1 gram and a delayed gram is why the data is not as good as the military findings. And I will have to say, as a young guy in EMS, Dr. Wayne was a big name back then, like Dr. Pons, and just really happy that he's in the audience tonight. And if he has any comment to chime in, I'd love to hear from him.
Well, may I be very quick? My days go back to the very beginning of the McSwain Wayne era. That was, I'm now 50 years in EMS and spent a lot of years before that as a trauma surgeon in Vietnam and elsewhere, where we began using whole blood. And then, of course, we went away. 2 comments on the TXA. We chose to go to that just because of the logistics of our community, and we were trying to implement a whole blood program. I spent some time with my colleagues in the military. I spoke with my good friends in the military in the UK, and unfortunately for what's going on now, Israel. And they believe that there is benefit, but only benefit in the 2 gram or greater upfront dosing. The problem with the 1-in-1, it was designed for OB and not for acute trauma hemorrhage. And I think it got confusing for people. So we do use the 2 gram up front. We give it as a continuous push infusion. Am I smarter than anybody else? No, but I'm probably older than anybody else on this call.
Thank you very much. So I'm glad to have been invited to do this presentation and me leaving tonight having learned something from you.
Dr. Wayne, thanks for joining us tonight and for your contributions. I appreciate that. I'm looking to see if there's one more question. One more comment about warmers not working well. I don't know if anybody wants to talk about that, but that appears to be a continuous problem.
Maybe Randy Schaefer could talk about that. Randy, could you?
Yeah, so I think when they're talking about the ambulance having a warmer on board, so we don't want to put the blood in those. We want to keep it ice cold between 1 and 10 degrees Celsius until right before transfusion. So I want to make sure folks don't get confused. If I understood the comment correctly about the ambulance having to build some warmers, that's good to keep other things warm, but you can keep both. I mean, you do it in a little mini cooler for the refrigerator, if that helps.
Thanks, Randy. Thank you. Well, we've gone 20 minutes past, and that was partially again because we started a bit late because of our technical issues. I want to thank everybody for joining us, and remember that this is what we do. You can join us the 3rd Thursday of every month, and if it's 8 p.m. and it's the 3rd Thursday of the month, we're here. You can be here too, and we're going to be talking about something. If we're not talking about stuff you think we should be talking about, talk to us. Let us know what you want to hear about. Let us know what you're worried about. Let us know what you'd like for us to do. And we've got, as you can see, tons of people, even if they're not presenting, they're here and joining the crew. So let us know and come and join us. Next month, Dr. Guy is going to be here talking about critical steps in pre-hospital burn management. And again, I talked about the fact that we're doing conferences in your area and the communities around the country and around the world. And if you think that you've got a site that would like to partner with us to bringing a McSwain conference into your community, into your area, contact us and we can talk about doing it. We've got conferences coming up over the next year. We're in Lynchburg, Tennessee in May. We'll be in Connecticut in June, Omaha in September, Mexico in December, and we're looking at possibly being back in Illinois in the fall or the winter. So this is what we do. If we're not doing something you want us to do, let us know. We'll work on it. We are eminently accessible. We are eminently accountable. This is why we're here. This is Dr. McSwain's dream, Dr. McSwain's mission, and that's why we're still doing what we're doing.
Will, you may mention Dr. Salomone is actually going to be speaking at the conference in Omaha in September.
Correct.
Midwest area. And you can visit our website and see the dates and the topics for the conferences as they become available.
Yep. The crew is going.
Lynchburg, Tennessee in May, and then Connecticut in June, in Omaha, it's September. Yeah.
Yep.
Not going on.
Yeah, and more to come. We've had some sideline conversations with some of you tonight, and again, all of you that join us, you're all part of our family immediately. The day you walk in the door is the day you're part of the family. So if any of these things are of interest to you, or you have an opportunity, or even if you think that there's no way it could work, we're your first resort and last resort. Go ahead and contact us, and we might, if we can't help you, we might know somebody that can. So thank you for being here with us.
Thank you.
Again, visit us. Remember that this is a nonprofit. We do this with money that has been provided us through Mary's contributions on her father's estate, the contributions we get from people that believe in this mission. But all of this is paid for by folks that we don't have to charge anything for activities like this, and very little when we come to town. So have a look. If you have an opportunity for us to work with you, if you have an opportunity to give $1 or give 100, whatever you got, have a look at our website and see what you might be interested in doing with us.
So Will and Mary, there are a couple of questions that have popped up about people asking for a copy of the slides. I don't mind. I don't know if you've done this for other presentations. I don't mind providing them to you guys in a PDF format. If people would want to email McSwain program and get them. Mary, Will, any comment?
I would prefer if you wouldn't mind. We can do that. I'd rather if you don't mind giving them your email, and then you can send it to them.
Okay.
Is that okay?
Yeah,
Just don't want us to. I don't want him to have to be a middleman.
sure.
Like
Anything else from the
now,
rest?
5 years from now, that's going to put us people wanting all kinds of slides.
All right, my email is in the chat. And I will send you a PDF format of the slides.
And it will be available on YouTube. Christy, you can upload it onto our YouTube channel, so it can be available there.
Yeah, I failed to mention that we have a YouTube channel, and all of our, we've been doing this for over a year. So anybody wants to see what we've talked about in the past, have a look there. Steve, did you have any, you've been monitoring the lines and going through this. Do you see anything that we failed to address tonight?
No, I don't. Just to recognize, Christy did post the website there, and also traditionally we get questions about verification of attendance. You can email us, and you'll see that in the chat where you can email and request verification of attendance for this evening's presentation. And again, next month, just to reemphasize, next month, Dr. Jeff Guy is going to be talking about critical care of pre-hospital burns in there. And again, third Thursday every month, as Will said, 8 o'clock, we're here.
Yep.
And you'll receive, Christy's very good about getting you on the email list and everything for this. And if there's other people that you think could benefit from us, let us know, and we'll see that they get the notifications also for this.
Yep. And regarding those letters of attendance, we've had pretty good follow-up with, if you turn that into your local EMS agencies, usually they'll find someone that'll recognize that as getting you an hour of credit.
Yes.
So thanks for joining us, and we'll look forward to seeing you next month.
Thank you.
Be safe.
Great job, Jeff, by the way. It was awesome.
Yeah, it was very good.
Really